Long time no see.
So I know. So I'm gonna just start my presentation today. Um, let's see. Record, chat more, present. How come it won't let me? I don't know why it won't let me meeting record on this computer. Where's my button? More. Huh. How come I cannot? Sorry. Record. Well, it's nice to meet you, everyone. If you don't already know me, my name is Jane Yi. I'm one of the other emergency medicine doctors from the University of Utah. I did my residency from 2015 to 2019 in Philadelphia before going to the University of Utah for a global emergency medicine fellowship in 2019 to 2021. Um, Today, I will be presenting to you about thermal illnesses as part of your environmental uh, module. Now, if only I can figure out how to, this is terrible, how to present my meeting. Presenter, let me see. Okay, maybe this will work. Share screen. Oh, finally. Okay, perfect. All right. Sorry about that slideshow. And today's lecture is going to be a little bit shorter than usual just because there's not that much to cover in terms of heat-related illnesses. Um, to begin with, a heat-related illness is when your body loses the ability or the capability to respond to a heat or temperature load or stress. And this exists on a spectrum of disease, and spectrum meaning that there is a continuous range of presentations and symptoms between the two defined points. So there's going to be a lot of overlapping as well as similar qualities in this disease process. And most of the time with heat-related illnesses, we like to categorize them from the two ends of mild to severe. And I like to think of it in these categories on the bottom because it makes sure I don't forget anything from mild to severe, from heat rash to sunburn, to heat cramps, heat exhaustion, and finally heat stroke, which we like to think of as the most serious or severe form of the disease. But keep in mind, it is a spectrum. And this is how I like to think of it. When you are in these more mild, less serious parts of the disease, it's more external. But as it gets more severe, you are moving internally in the body where it starts having signs and symptoms. It's hard to say where in this middle you start having the overlap, and that's going to be different from person to person. And you may even skip some things. It's just important to remember that it's going to be a spectrum of disease from external and eventually more and more internal. Now, this part is considered to be on the mild side. It's heat edema and heat rash. A lot of it, the pathophysiology, comes from your vasodilation of your blood vessels and your tissues from the heat. And it really takes some time to develop this. Mostly people who can't move, which are elderly people, will be the ones that you're going to see this more in. And unfortunately, it does not go away very quickly. A lot of this is going to be supportive care and symptomatic care. And it takes days to weeks to get better. A lot of times, this is just like any other edema that you are treating. You want elevation, you want compression, and of course, avoiding the exposure to the heat again and removing the exposure to the heat again. So, not something that we always think about, but yes, even in removing yourself from the situation, it can take a while to get better from this, but usually not life-threatening. And then the other part we think about in terms of the external or milder version of heat illnesses is sunburn. And I'm sure you guys who live in Vietnam, where it's warm, sunny, people, or at least American tourists, like going to the beach, you probably see a lot of sunburn. And usually, typically, we like to say sunburn at minimum is a first-degree burn. The new terminology for first-degree burn nowadays is just superficial thickness burn. And as you move deeper, you talk about second-degree burn, which is partial or intermediate thickness burn. And then third degree would be your full thickness burn. If looking at this person's skin right now, wherever you see red, that's at minimum a first-degree burn. Once you start blistering, you count that as a second-degree burn. But sometimes it might take a while to discover that underneath it could still be a third-degree burn. I am not covering it in this lesson right here because I'm sure in your trauma module, you guys talk about other mechanisms of burn. Here we are just talking about thermal burns, but there are other types of burns, if you remember, and if you were part of that module, that includes friction burns, radiation burns, electrical burns, chemical burns. And I'm also not really going to go over their treatments because that is really heavily covered in that module. But this is still something important for us to know, at least in terms of thermal illnesses. And a lot of this, you remember, is supportive care. Again, treat the pain, keep it clean to prevent infection, and removing yourself from the exposure. Along the other lines of mild heat-related illnesses, we think of heat cramps. We think of this as muscle cramps. A lot of it is in your calves. That's the most prominent area to experience this, but you can experience it in other places. And most of this is due to a combination of symptoms, which is inadequate hydration, so not enough water, which then causes your electrolytes to be abnormal, usually sodium. And then that causes, it's kind of a circle. You get heat cramps with it. When you combine this with hyperventilation and you get a respiratory alkalosis, you also get paresthesias. This is similar, and contractions of your fingers and distal extremities. Sometimes people can confuse this for muscle cramps, but they're somewhat related and in the same kind of less severe form of heat-related illnesses. In syncope, while it may seem more serious, it's still actually kind of in the mild heat-related illness part. And usually this is due to hypovolemia and then peripheral dilation. And if you can remember the pathophysiology, you are having a decreased cardiac output from this, as well as decreased cerebral perfusion. And that's how it precipitates the syncope itself. For most of these patients that prevent with mild heat-related illnesses, a lot of the times, most of these people do not come to the ER. But if they do, a lot of the times we can also help them fix it. So if they get better, most of the time they can go home. There are some rare instances where you say, oh, their sodium is way too low, it's too dangerous, it's too hard to fix in the ER, then these patients might come in. But most of the time, these patients will have a safe disposition home. And then we move on to moderate heat-related illnesses. We think about this as heat exhaustion. You have more systemic and serious symptoms besides from skin and muscle issues. This can include nausea, vomiting, the headaches. You can still have all the other symptoms from mild related illnesses too. But your other physical exam findings could still have the hypotension, the tachycardia, and like from before, you can still have the hypovolemia and hyponatremia. And often your temperature is around 38 to 40 degrees Celsius. Again, all of this is supportive care. IV fluids, check your electrolytes, stay away from the heat. And then you can start doing other measures if the person, your patient, does not seem to respond to your treatment. And that includes active cooling for the 30 to 60 minutes and then reassessing. And then what do we mean by active cooling? Hopefully this picture is a little bit helpful. And hopefully it's big enough for you to see, but there are different ways to actively cool people, and some of them is going to be more effective than others. Number one is the ice water immersion, which is the most effective treatment, but sometimes it can be hard to set up in the ER. This is something that they also do in really big races, where at the end of the race, for the runners in the heat or whatever, they have a big pool of ice water so that when they finish the race, these athletes can go in and submerge themselves. But if this is not something you can do in the ER, whether you don't have space or the equipment, the second most effective method, which we'll talk a little bit more about later, is misting, evaporation, and then ice packs and cold packs. And of course, we talked about fluids, but patients should be laying down, face up, and the feet should be elevated so you can bring back more volume to the person's head and heart. And then we move on to the severe heat-related illness, which is everything, which can include everything before, but you're added neurological and altered mental status symptoms with it. So again, same thing like before, tachycardic, hypotensive, but you are having other neuro symptoms with it and much higher temperatures. So you're just adding a little bit more, but they have a lot of similarities. And usually for heat stroke, there are two types that we think about, exertional and non-exertional. I think a lot of the times we already think of the exertional ones where you have an athlete who is in a race and they're exercising, or maybe at work, but they haven't had enough time to take a rest, take a break, stay away from the sun, or to drink enough water. And usually these people, when you see them, they're very sweaty. They have no impairment of sweating. And then you think about the non-exertional ones, which is a lot more common. We see it a lot in the US. I'm not sure about how it's like in Vietnam, but this is what we normally think about. And it's usually the very young or elderly patients, mostly because one, it's hard for them to get out of that environment. If you're a young baby, you can't move very well, or if you're an elderly person, you can't move very well. And if you're in a home without any cooling yourself, this can happen. And a lot of the times you will also see that they have anhidrosis. The lack of anhidrosis, though, does not mean you don't have a heat stroke. This is common, but you don't always have to have it. So that's just something to remember. And then we also have to think about what the difference between fever versus hypothermia, because it sounds very similar. You have a very high temperature in most cases in the body, but the treatment is very different, right? Fever, we usually think of it's less than 41 degrees. You can use something like Tylenol or paracetamol, I think you call it, or ibuprofen, and this will help lower the temperature. And they'll also have some rigors or shakes. And usually fever, we think about it in the setting of an infection. Your body is releasing chemicals and inflammatory agents that causes your body to heat up. Hyperthermia, on the other hand, there's a slight difference. Most of the time, it can be over 41 degrees. You may have it a little less if you're on your way to reaching that, but remember, it's an overlap. And things like Tylenol, paracetamol, Motrin, ibuprofen, aspirin does not seem to make a difference for it. In fact, if it is hypothermia, most experts do not recommend trying any of those medicines because it hasn't been proven to help, or at least there hasn't been enough studies to say this is not going to be harmful to your patients. So when we think of hyperthermia, then we have to also think of different diagnoses, right? Everyone that comes into the ER in the summer with a high temperature, it doesn't always mean that they have a heat-related illness. We still have to think about the other things that can cause you to have a high temperature, or else you'll treat them wrong or miss them, some part of their treatment and delay their care. So these are just some of it when you think about it. And if you really wanted to categorize this a little bit better, we can actually put it in a chart like this. So you have an elevated temperature. We talked about fevers earlier, and this is usually as the cause of from an infection. Hypothermia can be from production of certain chemicals, and then we talked about this most likely in the toxicology lecture, and I'm not going to go through all the details of this between your different syndromes here that can also give you a fever. And more on the anticholinergic and sympathomimetic. You guys see so much organophosphate toxicity. I'm sure you know this. And then some things are more internal, neurological that can cause a high fever. And again, here we are just focusing today on the heat exposure aspect. But do not forget about these other parts, because if you don't think about it, you will never treat it, okay? All right. So a lot of the times, heat stroke is a clinical diagnosis. For us, I don't know if you do this in the ER at Chorai, but we usually get a rectal temperature, a core temperature, to make sure this is accurate. We do labs. While it is a clinical diagnosis, we do labs to help guide our treatment of the patient and to figure out how severe things are going and if this patient maybe even needs the ICU. The liver, just because it's so connected to your muscles as well, is very vulnerable to heat illnesses and hyperthermia, as well as your CPK. And a lot of these, the PT, PTT, also related to the liver and its function. So it's something important to figure out how bad your heat stroke is, because again, it's a spectrum. We do possibly, not always, these other tests based on your history and physical, right? Because we can't exactly say there's no infection going on, but if they are able to tell you enough of the story or there's family to tell you enough of the story, then maybe you don't have to do an LP, maybe you don't have to do a CT. But sometimes we can't tell because remember, a heat stroke usually affects your neurological processes. So if a patient comes in is unable to tell you the story, unfortunately, you do have to go down the path of figuring why they have the high temperature. In terms of the management, not the investigation, I'm sure they talk about in all of your other lectures, checking the patient's ABCs, airway, breathing, circulation. But then the next step is to make sure you are removing them from the exposure, from the heat, whatever it is that gave them that high temperature. And we talked about it before in terms of active cooling. This is external, non-invasive. Cold water immersion is the best, followed by misting, fanning. That's also very easy to do in the ER. And then you can also change out wet towels on the patient and put it in very sensitive areas, which include the neck, the armpit, and the groin. There is such thing as invasive cooling or internal cooling inside, but it hasn't really shown that much evidence. And what do I mean by invasive cooling? So ECMO, which I know Chorai does a lot of, as well as cold water lavage. That means cold water into the bladder. Again, very invasive and hasn't really shown to be beneficial for your patient. So sometimes simple is what's best. So this is just a picture of how you can do the immersion in the ER. You see this patient here, this patient bed here with the sheets. They wet it, they put the ice, and then you load the patient onto the sheet and you wrap them up. What I have done in my ER is not actually use the sheets, but we use a body bag, the same body bag that you put dead people in. It's plastic and there's a zipper, so it's easy for you to put water and ice in there because it won't leak. So that is also one way of doing it instead of the way that you're doing in this picture. Again, I don't know how easy that is to do in the Chorai ER, but that is something I've seen commonly done here. Yeah, here's another picture. And this is our second best method. This is the evaporative cooling method with fans and misting. The water drying up from the skin has a cooling effect. So that's the second most effective method. And to touch upon some of the other things, while you are trying to cool the patient, you have to be careful not to make them too cold. So hopefully you have the central or the core thermometer in the patient, or if not, put it back in again, to make sure you are measuring the temperature and you're aiming for around 38 degrees because you don't want to overshoot it, which then causes its own complications. Again, with heat or thermal related illnesses, medicines don't really help that much to reduce the temperature. So antipyretics, dantrolene. For the other causes, yes, helpful. Now, in that process of doing all of this, we do end up giving our patients benzodiazepines or even pain medicines to relax them, because your body's natural response to the cold is to shiver. And your shivering response is to keep your temperature up. So you don't want to go backwards. You want all your treatments to be the most effective, not while the body is also fighting it. So it's important to consider giving them these medications because you may not see them lower their temperature fast enough if that's the case. And depending on how altered your patient is and how while they do or do not improve, you may have to give them paralytics and sedation to intubate them. But do keep in mind that a lot of these patients will have electrolyte abnormalities from hyponatremia as well as hyperkalemia, because you remember you're having a lot of muscle breakdown too. So we usually say to avoid the succinylcholine. Other things we kind of mentioned is using IV fluids, respiratory cooling, but again, not as good as the immersion or the evaporation method. And we already talked about ECMO and the cold fluid lavage. I guess if you really have to and the patient is really, really unstable, you can think about it, but most of the time, poor evidence. And then remember, we were doing labs earlier to figure out how bad your heat stroke or your heat related illness is. And also, we have to watch out for these complications from that. We talked about the liver enzymes, and the liver function tests. We talked about rhabdomyolysis, the hyperkalemia, but again, you can also have many other complications from it. So don't forget to treat those as well. And the funny thing is, with heat related illnesses, it can be fatal, especially in the classic heat stroke patients. The exertional heat stroke patients, they actually do pretty well most of the time because they're healthy, most of the time because they're moving on themselves and they just have to get away from the activity. So with the heat related illnesses, it's up to a 60% mortality rate, which is very high. And how well they do depends on how fast you can cool them, or really the length of time they are in a high temperature for. You want to reduce that as much as possible. Unfortunately, a lot of the times with your severe related illnesses, you're admitting the patient. Again, we don't know right away sometimes without doing labs, reassessing the patient, but usually they have a lot of things going on that needs admission to the hospital. And here's just a little table because I love my tables for a nice summary about what to do, a quick look. And I'll send this presentation out to you after this lecture so that you can review it on your own as well. So this summer, some funny things or not funny things maybe in the news here is that in the US, it's been getting very, very hot, very, very hot, a dry hot. We do not have a lot of humidity here in the Southwest. In Arizona, which is right near Utah, when people walk and they fall on the sidewalk, they actually get second and third degree burns from touching the sidewalk. And that's because the sidewalk is so hot, up to 71 degrees Celsius. So that's been happening a lot, such that their burn ICUs are at a capacity, at maximum. They're getting a lot of these patients in the ER. So again, I don't know what it's like over there in Asia right now, but this is us. And here is a Twitter of someone measuring the temperature. Unfortunately, this is all in Fahrenheit, but even in the shade, it's very high. In the sun, it's even higher. This is almost 160 degrees. So very dangerous. It's almost boiling water. And then when you're treating these patients, the last thing I would say is remember the vulnerable populations. This means the very old people, the very young, our homeless people, and our alcoholics. A lot of the times, one, it's hard for them to get out of the environment where they're exposed to the heat, but they also have other medical conditions that make it hard for them to get better or do well. Because remember, if you're, if you're an alcoholic and drink a lot, you may already have electrolyte abnormalities from that, and you're already dehydrated from not um, eating and drinking normally. So something like this can make your presentations even worse, or make it such you fall into the severe category even more. The other thing to remember is to remember the secondary causes to heat exposure. Um, I saw this a lot in residency where I had a very old grandma come in and she was 110 degrees Fahrenheit. And it was because she um, became sick. She was in DKA, and because she had diabetic ketoacidosis, she became so weak that she couldn't move at home to turn on the air conditioner. So then she came in with also a heat stroke. So sometimes there's two things going on at once. And then there's always secondary complications. Because if you think about, let's say, this alcoholic, their complication could be, oh, I was drinking too much and then I fainted out in the sidewalk and kept myself exposed there. So you have to think about the causes of why they could have gotten the heat illness in the first place and what are the things that could happen afterwards as well. Okay. Um, and then that is the end of my presentation. I don't have any uh, practice questions for you, but if you have cases that you've seen or would like to talk about, because I really don't know what kind of heat illnesses you see at Cho Rai or in Ho Chi Minh City. Um, Anything you would like to share?
Not really.
Do you see? No, you
Yeah.
don't really see this.
Why?
How
Why
about
is
in the countryside? I guess you have a lot of air conditioning everywhere. All these buildings, you just go into Circle K and it's okay.
yeah, it's just like
Here,
China. It's just like
yeah,
Taiwan.
yeah, yeah,
So
yeah, like China.
it's just like Utah when you are so hot outside, just go to Burger King or go to
Yeah.
Cash Junior. They serve you. They can bring we can bring water, free water or Coke or something like that, and we can go.
Hmm.
I don't know
Yeah.
why temperature is 71 Celsius degrees. 71, really?
The the sidewalk. So the air temperature, because the sun hits the sidewalk for so long, the surfaces of things get that hot. You know, when you go into the car and there's the metal part of your seat belt or
Mm-hmm.
even the handle of the door, because it's been in the sun and it's metal, it does get that hot
It,
here. So
it's melting, I think so. So dangerous, very dangerous. In Las Vegas, right?
yeah, I saw a patient with second degree burns to the bottom of the feet because she was running outside to her from the house to the car.
Mm-hmm.
It was very short, and she got second degree burns to both the bottom of her feet
So then,
because it's so hot. Yeah,
it, to come to Ho Chi Minh City is very good condition here.
I
It's
know,
not
I know.
too much humidity. It's too much humidity here. So
Yeah,
just but everything will be okay when you get used to live with that. All right. So
yeah,
weeks ago, maybe 2, 3 weeks ago, when the temperature is so high, maybe 40 degrees Celsius, some people get sick. Then we will have the heat stroke, something like that. But a minor thing. Nobody died for the heat stroke here in Ho Chi Minh City because we used to live with the heat. So if the temperature is so high, they go to the supermarket. They go to the mall. They go to Circle K,
yeah,
something like that, and everything's okay. And there is too much
yeah,
water.
yeah. Not that easy here. You remember, die.
Yeah, I
So
know
much
that.
open, big parking lots, big streets, no stores.
All right, I know that.
Stores.
Okay. So everybody
Yeah. Well,
have
does anyone
some
have any other questions?
new questions.
I hope to see you all in at VSEM soon.
Mhm. So
Oh,
again, I will write a
wait, my
letter
internet.
for calling, right, for the September coming. Dr. Ho didn't know
Okay.
to know for that Matt is leaving. He didn't know. I just asked Hannah for that, but she said that she didn't know about that. So I will write a letter including.
Yeah, I wasn't I yeah, I'm not sure who Matt has told. I think he's going in steps because he sent one to Dr. Tao and then he
Mhm.
sent one to some other people. So I'm slowly getting the emails to and I think he's just
Mhm.
going through his list now.
Okay,
So we'll see. Yeah,
we'll see.
I will I'll email you and keep you in the circle, in the loop.
All right, so that's good. Thank you for continuing with us, G, and hoping to see you here in Ho Chi Minh City, and we have a lecture in Charai and also in UMC too.
Okay, I'm excited.
All right,
Okay, thank you
so
everyone.
bye
Okay.
everyone.
See you next
Thank
time.
you. And bye bye everyone.
Bye.
Bye.